talk about in the next block is going to seem pretty mundane compared to some of the things that we've seen so far this morning. The main focus of our research in the Vascular Center over the past couple of years has been with the vascular devices, basically trying to find better and safer ways to treat patients with arterial occlusive disease. And we have been involved with a number of clinical trials over the past few years, primarily device-related trials, industry-sponsored device trials, including catheters designed to try and better cross chronic, hard fibrotic occlusions in peripheral arteries. We're involved in a study looking at a new laser technology to try and improve upon the laser debulking of atherosclerotic lesions in peripheral arteries. We've been doing some work with a covered stent in the peripheral arteries, and with a new inferior vena cava filter, try and find better ways to protect patients with DVTs from pulmonary emboli. Another area of great interest has been in the treatment of carotid artery disease less invasively, and we have been involved with several trials of different platforms for the treatment of carotid artery disease with stents and embolic protection devices. We have participated in a trial involving the use of stent grafts or covered stents for the treatment of abdominal aortic aneurysm, basically comparing the use of these stent grafts with observation for patients with smaller aneurysms, trying to decide whether we ought to be intervening sooner on patients with aneurysms now that we have these less invasive approaches to the treatment of aneurysmal disease. We've also been involved with some of the interesting work involving therapeutic angiogenesis or gene therapy. One trial that we've participated in involves the use of hypoxia-inducible factor for patients with intermittent claudication. And in the future, we're going to be participating in other trials looking at new stents in peripheral arteries, particularly femoral arteries, treatments for stents once they fail, when they develop intimal hyperplasia within the stent and re-narrow the artery. Better ways to protect the kidney during renal artery angioplasty and stenting procedures, much like we've used embolic protection devices in the carotid arteries to try and protect against atheroembolism going up to the brain, try and protect the kidney from cholesterol emboli or thrombotic emboli during the renal stent procedure. And so there's a whole variety of different technologies that we're looking at, again, to try and make the procedures safer for our patients. One trial that we were involved with, and Reggie actually used this technology in the coronary arteries, and we used it in the peripheral arteries, is the Crossor System, which is basically a device, a generator combined with a catheter, converts AC power ultimately into vibrational energy that's transmitted to the tip of the catheter via a nitinol wire inside that catheter. And ultimately, the catheter tip vibrates at 20,000 cycles per second to allow us to more readily pass through a hard or fibrotic chronic occlusion. And typically, these occlusions will have a fibrous cap that's difficult for us to penetrate with a standard guide wire approach. And so we can advance the catheter to this fibrous cap, activate it, and with the vibrational energy more readily advance through the occlusion, and then ultimately get down to the distal fibrous cap to allow us to penetrate that, successfully cross the occlusion such that we can ultimately perform balloon angioplasty and stenting on that lesion. And we participated in this trial, and this ultimately led to FDA approval of this device for treatment of patients in the coronary as well as peripheral arteries. Laser angioplasty has been around for many years in both the coronary arteries and peripheral arteries, but it's been limited by a variety of factors. One is basic inherent design of these catheters. They have multiple laser fibers throughout the catheter that allow us to deliver that laser energy to the plaque or disease in the artery. But in the past, we've never been able to create a lumen much larger than the catheter itself, which can be very limiting, particularly when you're treating blockages in large arteries. Until recently, when a very simple concept allowed us to perform more extensive or circumferential lasing or debulking of the artery. And this was basically a simple sheath that we could then mount the laser catheter on, and we could advance this entire system into the artery, make multiple passes through the blockage, rotating the catheter to again perform a circumferential laser angioplasty or laser atherectomy procedure, allowing us to create a lumen much larger than the diameter of that laser catheter itself. So a very simple concept allowed for more significant debulking of plaque or thrombus in the artery. And so we participated in this trial, the Trello Trial, which looked at this system in femoral and popliteal artery occlusions. And this is a patient that had total occlusion of the distal superficial femoral artery. A little hard to see for me to see from here, but here we can see the artery coming down and occluding distally and then reconstituting beyond that occlusion via these collateral pathways. This is what the artery looked like after the standard laser angioplasty procedure was performed, where a 2 millimeter laser catheter was advanced through that occlusion. You can see that a channel was created, but not a significantly large enough channel to result in a satisfactory angioplasty result. When we look with intravascular ultrasound, this is the yellow line depicts the outer adventitial border of the vessel. This is the catheter itself. The lumen that was created by that 2 millimeter laser catheter, you can see relatively small compared to the amount of plaque that remains in the vessel as seen here, relatively fibrous plaque. After advancing this newer laser platform through the vessel, we can see a much better angiographic result, but also on intravascular ultrasound, considerably more debulking of that plaque. We still see some residual plaque, but a much larger lumen seen here is outlined by the red. And then if we can go back and finish up with a little bit of balloon angioplasty, see again continued improvement in the angiographic result and a much better lumen with some compression or redistribution of that residual plaque as seen here from around 10 o'clock to 2 o'clock. So again, this study we participated in ultimately led to FDA approval of this newer laser system for peripheral arterial use. There are a variety of stents that are available for coronary and peripheral vascular applications, both balloon expandable stents as seen here. Typically a stainless steel or a cobalt chromium stent is hand crimped onto that balloon and deployed in the artery when that balloon is expanded. And this is just a magnified view of one of these balloon expandable stents. And then there are now a whole host of self-expanding stents. Most of these are made up of nitinol, or constructed of nitinol, a nickel titanium alloy. And when these devices are deployed in the vessel at room temperature, they expand to a predetermined diameter, and we can deploy these within lesions and then go ahead and further expand them with a balloon afterwards so that they can achieve a more ideal lumen. There are now covered stents that are available for arterial use, and this is a balloon expandable covered stent. It's a stainless steel stent framework with a PTFE covering over that stent. This is a scan and EM picture of that device showing the very tight structure of the PTFE, basically a double layer of PTFE over the stainless steel stent. There are a variety of potential applications for these covered stents, including the treatment of aneurysms or false aneurysms in arteries, for the treatment of complications of our procedures, basically vessel rupture or perforation, but also potentially to reduce the complications of stenting, reduce the potential for distal embolization by trapping that atherosclerotic or thrombotic material behind the stent, and potentially to reduce the risk of late re-narrowing or restenosis of the vessel. Basically, that ePTFE can serve as a barrier to the neointimal regrowth that happens within stents and ultimately causes the stents to fail or to close. And I'm the principal investigator for a trial that's ongoing looking at the use of these types of covered stents for iliac artery occlusive disease. This was the first patient that we treated as part of that trial, a patient who had total occlusion of the left iliac artery. We see the abdominal aorta here, the right iliac artery, and an absent or occluded left iliac artery. And this was after deployment of a couple of these covered stents in the left iliac artery, showing a nice angiographic result. So there's great potential here to improve upon the results with angioplasty and stenting in some of the peripheral arteries, and we'll look forward to some of the results from this trial. As mentioned, there's a lot of interest in the use of stenting in the carotid arteries as an alternative to carotid endarterectomy because of the potential morbidity and mortality associated with carotid endarterectomy. And we have, again, participated in several trials looking at different stent and embolic protection devices, platforms for carotid artery disease. This just depicts how these lesions are treated at the carotid bifurcation with an embolic protection beyond the stenosis or occlusion. The stent deployed across the lesion in the carotid artery. This is the fluoroscopic appearance of one of these stents. In the cartoon, again, showing how these devices are deployed and how they can be used to treat atherosclerotic occlusion at the carotid bifurcation. Most recently, we've participated in a trial looking at a newer embolic protection device in the carotid arteries. This is the Fibernet embolic protection device, and it's a device that's really mounted on a very low profile guide wire, a 14,000th inch guide wire that can then be advanced across the stenosis in the carotid artery, and then the filter can be deployed, and it's really just a tight weave of fibers that when it's deployed, it's like a disc that is opposed to the vessel wall beyond the occlusion, and this tight weave of fibers can trap any of the particulate material that's released during the carotid stenting procedure. And then as an additional safety measure, a catheter is advanced over the guide wire to the filter, and we aspirate any loose particles that might remain in the vessel after the stenting procedure before we collapse that filter and remove it. And the trial that we've participated in is the EPIC trial, which just in the past week completed enrollment. We had enrolled a number of patients in this trial, and we'll look forward to some of the results from this trial in the weeks and months to come. One of the other interesting concepts that's being looked at for the treatment of carotid bifurcation lesions is the concept of proximal occlusion with flow reversal in the carotid artery while we're working. So we can basically put in a platform where we deliver a balloon on a guide wire into the external carotid artery, inflate that balloon, then inflate a balloon in the common carotid artery, a balloon that's basically mounted on the sheath that we're working through. We can occlude flow in the carotid artery while we're working, and then actually through gentle aspiration or through creation of an external AV fistula, create flow reversal in that carotid artery while we're working. So there is then no potential for emboli to move distally into the brain during the procedure. So we can then go up with impunity, dilate the lesion, deploy a stent while this flow reversal is ongoing, and capture all of that material and basically totally reduce the potential for embolization during the stent deployment and stent post-dilatation. So this is just sort of a snapshot of some of the things that we're doing currently with our clinical trials. Clearly there are a number of unmet needs with regards to vascular intervention in the arteries outside of the heart. Although we've had great success with drug-eluting stents in the coronary arteries, they have not been developed and tested well in the peripheral arteries, and in the minimal experience to date, there hasn't been a very significant or positive response to drug-eluting stents in femoral arteries. There has been some preliminary work showing promise with drug delivery from balloons into femoral arteries during the balloon angioplasty procedures. And there is some early work being done with alternative techniques for drug delivery into the vessel or into the periadventitial space with a catheter that has a small needle on it that can be advanced through the vessel wall into the periadventitial space during the interventional procedure. And this would be a potential application or a good application for the microneedle technology. If we could deliver drug into the adventitial space during the intervention, that would be a great way to blunt some of the response to injury during these procedures and potentially reduce the risk of restenosis. We're still looking for better ways to cross chronic total occlusions. Arteries that have been blocked for months and years become very hard fibrotic occlusions, and we still do not have good ways, particularly in the coronary arteries, to cross some of these chronic total occlusions safely and treat them effectively. We're looking for better ways to safely remove thrombus from arteries when we go in to treat thrombotic occlusive disease. There's still a significant potential for embolization of this thrombus during these procedures and complications because of that embolization. We're looking for better ways to protect the brain and the kidney during interventions with embolic protection devices like we showed already today. And we're always looking for better ways to assess the results of our interventions. Certainly a lot of limitations to just injecting dye in the vessel and doing x-rays. We often miss things, or we don't have a good hemodynamic assessment of our results. So some of the visualization techniques that we've seen today could have significant application during peripheral vascular interventional procedures. And with that, I'll stop and be very happy to answer any questions. And thank you very much for your attention.
Just one or two brief questions for Dr. Laird, or we'll save it for the panel. Yes, Dr. Conley.
So I'm just wondering for the CTOs, you're hoping, of course, that for the chronic occlusions, I assume you're hoping that you're going to be able to have myocardium that's still maybe hibernating, not yet dead. Is there any initial numbers on how often that is the case?
Well, we have pretty good technology now to evaluate for viable myocardium through a variety of different nuclear imaging techniques as well as PET scans. And echo, even echo with pharmacologic means. We can have a pretty good idea of whether there's viable myocardium downstream from the occlusion. And also, of course, if the patients have continued anginal symptoms, we'll have a pretty good idea whether they will benefit from opening up the occlusion. So, but the challenge is getting through there safely without perforating the artery or disrupting or dissecting the vessel or closing off collateral vessels, which might be important for that patient. That's the same issue we face in the legs too. We get these heart occlusions that we can have trouble getting through without causing perforations or other sequelae.
Thank you very much, sir.
Thanks.
All right. If I could trouble you.